Greetings, everyone. This is Wacana English Edition Podcast, and I'm Atira, taking you to our new podcast show that gives our viewers insight into the political, economy, and social landscape of Malaysia. Today is our first episode on podcast format for Wacana, where we are looking to have a more frank conversation on pressing matters that concern our nation. And on today's episode, the first episode actually, we will be talking about conditions and problems that our public healthcare system is currently facing. As we all know, we can see it every day on social media, on Facebook, on Twitter, where medical officers, healthcare workers are sharing their concerns. And our public healthcare system has been on stretch since the pandemic began. While things are still going back to normal, but the public healthcare hasn't recovered as healthcare workers are being overworked, understaffed, underpaid, and working in badly maintained facilities. All these factors have greatly influenced their quality and capabilities to provide patient care. Clearly, it has given a big impact to the people, to the country as we are moving forward post-pandemic. With all that in mind, let's dive deeper into this topic with our expert joining us today. Professor Dr. Sharifa Ezat Puteh. She is a professor from the Faculty of Medicine, University Kebangsaan Malaysia UKM, that specializes in health, economy and public health. So welcome, doctor, and thank you so much for joining us today, Dr. Sharifa. How are you feeling today?
Thank you, Atira. I'm well. Thank you for having me here.
Okay, so as I mentioned before, we see it every day on social media, in the news, on television, rumors of strike, manpower down, patients losing their patients in emergency departments, lack of beds, badly maintained facilities. So now we want to know, how did it become to this? How did it succumb to this? What happened exactly? Can you share with us?
Right. Well, Malaysia is basically a middle-income country. That means our GDP per capita and also our facilities, this is not considered developed countries. We are considered an upper middle-income country. So our sort of friends in these areas would be, something like Thailand and things like that, middle-income country. Our healthcare are already under pressure from the start. Actually, we have been under pressure for many, many years, but it has escalated due to the last pandemic. We just sort of, not to say recovered, but we have just gone into the endemic stage of COVID. There's a lot of backlog of cases that just settled by the Ministry of Health. I think the Ministry of Health is trying their best. They are definitely under pressure to come up with the best services, quality services to the patients and the populations, and they are trying to cater to a lot of demands from the public, and of course this put a stress to the population. Most of our funding comes from the tax-based system. So if you know the tax-based system, this comes basically from the population's pocket. So we are not the private. That means we don't actually incur a lot of fee from the public. Of course, there are sectors what we call as the full-paying patients. Even in the public healthcare system, this is to gather or to garner income for the facilities. But basically, these are tax-based. Basically, they come and they pay very minimal fee, and this minimal fee would not be sustainable in the long run. It's what you have mentioned correctly, Atira. The fee is actually very, very small, and it has not changed for many, many decades ago. So this sort of fee, the fee is very small. There needs to be a revision to improve income to the facilities, but also the public has to take ownership of their health. This ownership of their health, the health literacy and health empowerment needs to come from down. That means they need to be knowledgeable about self-care, but also have to better take care of themselves. I give you an example. As probably aware, most of our national surveys have shown that our diabetic, hypertension, stroke, cancer, what we call as the non-communicable disease. This is one of the biggest burden on the healthcare at this point in time. Most of our money are basically trying to fight these so-called NCDs, and most of these patients are being monitored and they follow up in the health centers, and of course in some cases they go to the hospital for follow up in the specialists in the hospitals. if they get complications of different comorbidities and things like that, they get admitted in the hospitals, right? So this puts a lot of stress to the public sectors, and as has been mentioned repeatedly, we can see there's going to be an overburden of people in the wards. But also we need to better take care of ourselves. Things like, reduce obesity, reduce sugar intake, cholesterol and things like that. So if the public, or basically the population, are able to manage their health in that sense, are able to curtail all these, probably not to say simple, but things that put a risk, smoking and things like that, we are able to reduce our health impact and health conditions, so that you don't get admitted and you don't need to be followed up, repeatedly in the health centers.
And earlier you mentioned that the fees are not sufficient to cover the hospital bills and all that. So how does that impact patient care?
Right. Ministry of Health basically obtain their funding, or they receive the funding from the government. Basically, so it comes through the Ministry of Health. Ministry of Health get it from the Ministry of Finance, and of course Finance get it from the government through the tax and so forth. But most of the budget that comes to Ministry of Health, we have repeatedly mentioned it, and I think this is one of the things that come up in the white paper as well, that the budget devoted to health is not actually adequate. Even though the budget actually keeps increasing year by year, this is still not at par with, of course, the developed countries. But the budget is not enough, because you see, once the budget comes down to the health side, or basically to the health side or medical side, it goes into two parts. One is the hospitals, but another part, or one big part, is also go into the public health sectors.
Okay.
And you need to actually think about the primary care as well. So the primary care, this is where the health centers are. And if you talk about public health, this has been under strain, budget-wise, financial-wise, for many, many years. But you see, most of these communicable disease, meaning like infectious disease, dengue, COVID, these are basically screened and tried to be managed at the primary care and also public health sectors. So we definitely see that you need a more budget on these sectors, right? Improvement in the hospitals, of course, this come hand in hand. But if we are able to reduce admissions, or basically people come with complications, then basically we don't put a stress to the hospitals. Most of this can be managed in the health centers if they do come early and they are managed wisely in the health centers and also the clinics. This would actually reduce our strain as well. But this is not easy to be done, Atira. We keep saying that this can be done, but this is not easy, because one, you need to know, you need to make sure that the public really knows what they do, what they implement, The second part is that you also need to implement some essential drugs for them as well, devoted for them in the primary care as well. So this is very important. It needs to go hand in hand. I'll give you an example. If a person goes to the hospital and they have been diagnosed with cancers, and they find that the service is cumbersome, they get scared by the advice from maybe certain doctors or things like that, they might actually go into the complementary or alternative medicine, and this can actually impact the prognosis of the patient. And this negative impact can actually be seen in many circumstances. We have done research. There's many studies that show these things occur again and again. So how we manage the patient is actually not easy. How to make sure that they know what to do, how to reduce their feeling of uncomfortableness and things like that. And so and you must be aware as well, people who man these clinics, we're talking about the public clinics, they are also under stress and under duress, because they keep seeing patients again and again. In some circumstances, the medical officer or the doctor in the primary care may need to see maybe hundreds of patients from the morning till the evening. At a certain point in time, they don't even have time to actually take a break. They don't even have time
we have
to
seen
go
that
to
happen.
Correct. And that puts a stress on them mentally and also physically. Of course, they get tired, but they put up a lot of, a demand from the patient. They themselves become emotionally unstable, and this actually makes them more prone to conflict. Then they start to raise their voice and things like that. We see this again and again, but it's not easy. It's not easy. We can't really say that it's different scenario now. When we were young, when I was doing medical many years ago, the mentality is that we give advice to the patient. At this point in time, with the high IT and things like that, it's more of a discussion with the patient, and that needs time and effort.
So it's like sort of like a domino effect from one person to the doctor to the long-term effect.
Exactly. But most patients, or basically the population, they flock into this public sector because of the low cost. Now, the government has been trying to shield the population. They don't actually increase the price. They try to provide the best medicine, with that amount of price. And it's not easy, and you can see that impact happening subsequently now, right? So with the pandemic and people losing their jobs, financially they are not equipped to deal with healthcare, increasing healthcare costs. Most of this would flock to the public sector, and we can see this in the ED, we can see this in the public hospitals, and we can see this in the health centers as well.
Okay, and Dr. Sharifa, you are part of the 60 experts that met with the previous Health Ministry, Khairi Jamaluddin, on the creation of the white paper. So can you share some of the solutions that have been put forward to address these problems specifically? Right. Has it, can we expect anything from it?
Well, the white paper actually consists a lot of experts, yes. Okay. I went through the United Nations universities as well, and what basically people or experts at that point in time looked at the human resource, whether there needs to be any new governance in place, and how to make sure that the sustainable health care can be provided at this point in time and as cost effective as possible. That is, again, it's a very tricky question. It goes back into funding, it goes back into financing. So one of the strategies that has been proposed is actually to come up with some sort of insurance, what we call as the national health insurance or social health insurance. It has been practiced in many other countries before, things like Taiwan, South Korea, even Thailand has come up with some sort of health financing of some sort. And the recent is also Indonesia. They have their own health insurance, and basically these are for the low income, also a bit of the middle income as well. And when that happens, most of these reimbursements for costs comes back from the government, goes through the government, right? So what happens to the patient, or basically the population, they can actually attend a choice whether you can go to the public sector or you can go to the private sector, where at this point in time we can't unless you have money, right? So if you want to go to the private doctors, you need to make sure that you have money to pay, or you are covered by your insurance, or basically your employer pays for you, employment-based coverage. So if you have this sort of social insurance, as a patient from the population, you are able to go either the public or the private, but your payment will not come from yourself, because this puts you at risk. It will be borne by the government through some sort of reimbursement packages, right? So something like what insurance is doing. So at this point in time, we don't have that. The only one covered by so-called something like social protection are people in the SOCSO, and of course people which are covered by the government are Peke B40, and also My Salam. So these are some of the social so-called protections that are already provided. It is not enough. You can see that the number of people attending Peke B40 and My Salam are increasing. A lot of people are going into catastrophic health expenditures. They obtain chronic healthcare problems, things like cancer. Immediately you need a lot of income for that. A lot of budget goes into that, even if you attend the public sector, because cost of oncology drugs, cost of oncology drugs are tremendous, and most of the time you have to pay up front first. Even though the cost is much cheaper than the private, you still have to pay some sort of budget for that. It depends on which cancer, which treatments and so forth. So these sort of scenarios are changing in certain countries. So some of the proposals include, proposing a national health insurance for the country.
And I feel like everything goes back to funding at this point.
Unfortunately.
Unfortunately. And we're going to discuss a bit further on the white paper, but we're going to take a short break and we'll be right back.
Politician? Why is the word politic and geomanagi is so synonym? Oh my god.
We are back with Wacana English Edition Podcast, and today we are joined with Dr. Sharifa, where we were discussing on the current state of our healthcare in the country. And earlier we were touching a bit on the white paper and the impact on the patient care right now. But then again, we want to go back to basics, doctor, and educate those who might not understand. With the contracts and the contract doctors and pharmacists, why most of them are not taken in as permanent staff? Because without them, no one could cater and take care of the patient who comes into the hospital. What are some of the hurdles or roadblock they faced to be taken in as permanent staff? We want to know.
Right. If you understand how the public service works, there is a quota, meaning that there's a ceiling of how many personnels that the public service are able to pay per year. So healthcare is one of the sort of sectors that actually curtails a lot of budget from the Ministry of Finance. So having said that, most of the doctors, young doctors, we're talking about young doctors and also probably young pharmacists that you mentioned, when they graduate, some of them are not taken in. One is that were they previously financed by the government? Example, were they financed by JPA, MARA, or things like that? If they were, most of the time they are going to be taken in. It's just a matter of time because they were financed previously by the government, and the government needs to actually make sure that their investment are worthwhile, so they are going to be taken up. The second part is that if they are not from the government or they are not paid through the government, scholarship or things like that, this is where the problem is. They have to compete, and the problem is that the placement or basically the number of people or posts are actually very small. Now these posts are not actually made by the Ministry of Health. They are actually, even though the Ministry of Health can say that you need this amount and things like that, because we have the ratio, right? Example, a doctor, you need to have about 200 population per ratio of one doctor. That's in a way that would be the optimum, And this is not achieved throughout Malaysia. There's some countries or some states in Malaysia where you see the ratio is actually very high, as you mentioned. Same thing with nursing and pharmacists and physiotherapists and so forth and so forth. The issue is that the posts are not there because the budget for these posts comes from the PSD. Basically, it comes from our JPA and also our public service department, and they have the last say. Now, the issue is that if there is another way that the funding for these so-called young doctors can be put in place, then the so-called this hospital are able to actually take up these doctors. But where does the money come from? So that's the issue. Because remember, the post is not enough. Example, one hospital may have 100 posts for housemen, example, but the influx of doctors may be more than that. So they really have to select which are the best housemen or pharmacists to be placed in that hospital, and that can be in contract basis as well to make sure that whether you perform and things like that. If not, then basically you're out, and things like that. So this is actually a very trying times as well for them. We are heading somewhat, probably not as bad. At one point in time, certain other countries like the Philippines, they have a surplus of healthcare personnel, including doctors, where even sometimes the doctors do not work as doctors. They actually go down and work as nurses, pharmacists. They do even go out of the country to work elsewhere because there's just not enough place for their hospitals, even though actually the healthcare actually needs them badly.
But in the long run, isn't that going to snowball? Because we have graduates every single year, young doctors completing their housemanship and everything. Then how about the long run? What about the people who are waiting now? Do they have to wait for another 3 years to get a spot? And by then we might have new graduates who completed their studies.
Yeah, this is some of the things that was previously done by certain members of the government and also the private sector, where there's a lot of medical schools mushrooming, not only locally but outside, and we keep sending, and we do not actually forecast on the intake later on. So this leads to the issue now that we have now, too many doctors, too many young doctors, too many pharmacists.
Too many of everything.
Too many of everything. But if you look at the end point, we don't have enough doctors to actually manage in certain areas like the rural area, East Malaysia and things like that. So this, juggling of two forces, which is mind-boggling, and leads to, of course, accumulation of doctors year per year, and we are actually creating a lot of dissatisfaction in the healthcare because you see we already have an existing healthcare force, and these are young doctors with a lot of motivation and trying their best in the area, and most of them would either go in the private sector, but they are not sometimes able to practice as a specialist later on because the competition for them to go for masters or postgraduate degree as well are also very competitive. it's not easy to come up with a specialist, Atira. And the issue is that, again, the posts and the areas where they can actually train to be trained as a postgraduate and later on as specialist is not enough in the country. A few private hospitals that I know of, things like KPJ and all, they are actually, have started something novel, training for specialists in the private sector itself. Now, this has not been done before. Most of the training for postgraduate are actually done in the public sector, things like university hospitals and things like that. But only now that they have started with the private sector. The issue is that there is an issue as well. Who is going to fund this sponsorship of these doctors? Because they are either self-funded, that means they have to fund their own. They can actually obtain some sort of scholarship or some loans and things like that to make sure that they go through the postgraduate for maybe 4 years or maybe extension of 1 year or 5 years or something like that. And later on, they need to pay back or basically work in the hospital again. But with so many doctors, this opportunity is actually very small.
And the fact that you mentioned earlier, because I saw on Code Blue some stories shared by young doctors, contract doctors, where he himself are the only one left at the hospital. The rest of his batch has left for private hospitals and also leaving the country, as you mentioned before. This is currently happening to us right now, and we are facing a severe case of brain drain with more workers choosing to leave public hospitals to work or working outside of Malaysia to make more financial decision and choosing to leave the health sector altogether. So what can be done to stop this?
Right. One of them is that the one that I mentioned, if they are able to come up with some sort of training in the private sectors, and if other entities or other organizations, things like what has been done by KPG and so forth, that they are able to train these young doctors to become specialists and basically work in the government side. But most of these young doctors, once they become specialists, they will work in the private sector, which is again a loss for the public sectors. The second part you mentioned about correctly, a lot of doctors, even young and also the more seniors, because once they are senior doctors, most of these doctors are very highly trained in their specialties, either medical, surgical, or even in health management and so forth. So they are usually grabbed by the public, by the private sector or even overseas. And again, it causes a lot of deficit in the country. We are not able to sustain this in the long run.
Yes.
We need doctors. We need them. But unfortunately, we are not able to come up with competitive price and emoluments for them. And this is one of the reasons that they leave. So the brain drain has been occurring for many years, and we are going to expect, this is going to occur some more. Of course, if we are able to finance them through some sort of funding or some sort of, better emolument and better working conditions for them, then we are able to sustain them in Malaysia itself. One of the ways that the government has done this, is that they have actually set up some sort of a private entity themselves in this public sector, even though it's a public hospital, but you have something like a private side. So this private side, example, for Ministry of Health, we call this the full paying patients. So the patients have to pay fully as in private. Of course, the cost might be a bit more competitive. It's slightly less costly, but they have to pay. So these costs are given back to the specialists, and the rest of them will be obtained back to the government. So this will keep the specialists happy, and they are able to stay in the public sector as long as there's some leeway for them to work in the private sectors.
I agree, because again, on Code Blue, we saw the survey, 80% healthcare workers are claiming they are underpaid, 78% complain of being overworked, and 74% suffer from burnout. And we already see on Twitter, like today we saw a psychiatric patient stab an elderly man for waiting for a long time. But then again, it's not the hospital's fault because they were lacking of manpower. But then what can the Ministry of Health do to address this issue in solving the crisis, short-term and long-term, Doctor?
Yeah, one of the ways is that make sure that some of the patients do not get admitted in the first place. That means keeps them healthy. Maintain the population as much as possible so that the population is healthy at their level. That means the primary care and also the public health, make sure their population is healthy, keep them healthy so they don't get admitted. They don't need to see the doctor at the hospitals. They don't need to get admitted and so forth. The second part is that if you do need admission and so on, one of the ways is that you work together with the private sector, right? So that these patients, and this has happened, example during COVID, where these patients, even though you obtain COVID, you get admitted to the private sector. But of course, in certain situations, they don't need to pay. Now that's the problem. It goes back to payment and who pays for these diseases. So if we are able to work up with some sort of social protection, example for the Peker B40 or My Salam, if they get admitted, now they are able to see some doctors in the GP as well, the private clinics. But if they are able to get admitted in some sort in private hospitals, but the payment or basically the subsidy comes back from the government. This is one way of looking at it to decongest the private sector to public sector, decongest the public sector.
Why do I feel like everything is going back to the funding, doctor?
Well, yeah. The second part is that the community we need to make sure that we are self-literate and we are able to self-care on our own. Meaning that not to say that you treat yourself lah kan. Meaning that you are able to better take care of yourself. Delay the disease as much as possible, not to get diabetic or stroke or hypertension as early as 30 years old or things like that, so that you better take care of yourself. And basically this is through maintaining a healthy lifestyle. Don't smoke. If you have not started smoke, please don't smoke. If you have started smoking, please stop. Obtain treatment, NRT or things like that, and make sure that you maintain a healthy lifestyle.
Okay, so that's basically it. We have to the funding and practice a healthy lifestyle to avoid, maybe to take care of our healthcare system. It is definitely a complex problem that require a comprehensive solution to ensure our public healthcare workers' welfare are taken care of, and also ourselves, because we can't really do anything going to the hospital. We're sick, we don't have any medical officers and whatnot. So that's all the time we have, doctor. Thank you again for spending time with us. To those who are watching, thank you so much for tuning in to Wacana English Edition Podcast. Make sure to follow Sinar Daily on all of our social media platforms and our portal at sinardaily.my for the latest news and updates. I'm Atira Manudin, signing off for Wacana English Edition Podcast. See you soon.